Hello everyone. Okay, so my name is Javeria. I am going to be your host today for our Health Equity Town Hall for MCC. We've had a few other town halls before too, so the focus of those is more on other topics, but today's topic is going to be on promoting health research programs to reduce the life expectancy gap using the Mosque-PCOR Toolkit. Okay, so if we can have the next slide. All right, so the format for today is going to be, we'll have an hour and 15 minutes, inshallah, to introduce the topic, introduce the mosque community, what we've been doing, and then also give some background. Dr. Patel is going to give us some background on mosque-based health programs and research, how that's carried out, what are the factors that go into that, and what are the things that we can all do to work together to kind of increase our research, increase our understanding of research and how it is important for us to involve mosque communities, what are the problems, all of that. And then we'll end off with a panel discussion with our wonderful panelists, and then have questions with the audience and discussion with the audience. Okay, so yes, beginning will be the welcome. We'll just discuss what kind of the basic of the town hall, what's going on. We'll start out with a intention, so a prayer to God asking to give us some benefit, and then we'll talk about what is PCOR, the PCOR toolkit, what we've been doing, some background, and then defining target population, defining what we're going to look for, what we have been looking for so far, and all of that. All right, and then we'll go and we'll have Brother Ishaq go through what specifically MCC has done, and then Dr. Padella will talk about specific examples of research, how the disparities have, how they present themselves, how we can build a culture to bridge the gap between the disparities in the culture, and then the partnered research that we've had specifically with MCC for this year and what we plan to do. And then we'll have a little break so that we can refresh and kind of absorb all that knowledge. And then we'll have, inshallah, a panel discussion and moderated discussion with some questions that we've prepared, and kind of work through all of these things together. Just some housekeeping items. The webinar is being recorded, so I hope no one minds that. And just so you know that it is. Participants are going to be only in listen only mode, so only the panelists will be able to speak, but you can say any comments, write any questions in the chat box, and we will have people moderating the chat box. Just in case you get unmuted in the rest of the discussion, so it's until your turn, just keep it muted. And then anyone can submit a question for the panel. We do have some questions that are already prepared, and then we'll look through the questions that people have given us so that we can go through and answer those as well. Okay, we'll start out with the prayer. So Bismillahirrahmanirrahim, in the name of God. Allahumma na'ni bima allamtani wa allimni ma fa'uni wa zidni ilmi. Allah, make useful for me what you taught me, and teach me knowledge that will be useful to me and increase me in knowledge. So it's important to start out with a prayer of our intent, because that is one of the factors that works with mosque communities, is that we like to, these are the things that we incorporate into our lives. And so it's important to start out with the spiritual aspect as well. I was already introduced, so I'll skip that. So Sister Fatma, do you know how the poll works? Do you want to introduce the poll?
So Masood is going to be administering a little poll right now. The panelists can take the poll quickly. We just want to gauge who we have and compare it to the poll that would be administered at the end of the session. The panelists actually don't need to take the poll. It doesn't work for the panelist. Host and panelist cannot vote. So we'll just give it a minute. All done. Still coming in.
64% done.
Okay. Okay, the polls are still coming in.
80% done.
Okay. All done?
Percent.
Okay. So let's move forward. Okay.
All right. So let me just get do a brief introduction for PCORI. PCORI's mission, for those of you who don't know. So the goal of PCORI is to help people make informed healthcare decisions and improve the healthcare delivery and outcomes using like high integrity evidence-based information that we include patients in on, their caregivers, and the whole healthcare community. So usually research is like the researchers, the scientists, and the subjects, but in PCORI, they're trying to get involved everyone because it is so relevant to their lives. And people have found, and we have found, and I've been learning in this past year, that doing it this way involves people, incites their passion, invites them to get more involved and give more accurate information, and like it gives us more accurate information because it is people-centered sorry, something just popped up. People-centered research, because it's about our health and it's about the things that we do. So some of the strategic imperatives that PCORI tries to work through is engagement, which I was just talking about, engaging the patients, the caregivers, all these different stakeholders, which includes insurance companies, it includes hospitals, it includes the doctors and the patients and the caregivers. So that's mainly what we've been focusing on in our project. There's these 5 pillars of the PCORI strategic plan. So you have, of course, engagement, which we are mostly involved in. You have the method, so trying to develop and promote all of these things. The research, of course, because these are all connected, and then disseminating what we find in a way that's understandable for people and useful for them and is more overarching as a whole. And then after that, also putting into action by putting in infrastructure to help promote the things that we find in all of, and continuing patient-centered outcomes research. So next slide. Okay, so background, the purpose of this town hall. Part of engagement, part of getting everyone involved is to make things accessible, let people know what we're doing, who are the players that are involved, what kinds of things we can do with the information that we find, and how people can contribute to that overall, whether it's the patient, whether it's healthcare, health systems, clinicians, and the data, just kind of making everything come together. So one of the concepts that we use in the PCORI centered and in this project is like building partnerships and facilitating this co-learning. So that involves everyone, and that's the purpose of the town hall, so that we can get involved and engaged for that. The next slide. Yeah. So let me give you some background on how the PCOR Toolkit, which is what we've been using, has come to be. So from January 2017 to December 2019, I believe it was Sister Fatma and Dr. Padella have been doing this one, the first Mosque-PCOR project, which is engaging Muslim Americans for research on community health, eMarch for short. They had a conference showing their findings in October of 2019. Most of the things that they found out during that thing were centered around communities and getting involved in communities and what things worked and what tools we could use to effectively engage the community, to effectively do research. Most of it was before COVID, which brings me to the second Mosque-PCOR project, which is what we have been part of, which is equipping Muslims with PCOR-based action-oriented research tools, or MPART for short. So we use the PCOR Mosque Toolkit to try to engage communities, the community health workers. We did outreach, we tried to get information from mosque communities, and then we trying to disseminate that information and engage with the community now with these town halls. And then it will have another symposium, the second Mosque-PCOR project symposium in September upcoming. All right, so again, we've been trying to disseminate these tools that were found out from the first research project, and Dr. Patel will go through some of the concepts of these later, where they include like the 3 R's and how to engage people and what setbacks you can overcome, hopefully using the Mosque-PCOR Toolkit. All right, and the next slide. All right, and then just an overview for the MPART timeline. In August, the CHW's community health workers were recruited. We did a whole month of training. Then we connected with the different mosque communities. Then from December to May 2021, we did outreach, which included calling people, manning the phone line, manning the text messages and the emails, and doing programming with the different mosque communities, like helping out and finding out about, like, for instance, like the COVID-19 vaccine clinics, informing people about what they could do for getting coverage, things like that. And then afterwards, now we've been doing the 5 town hall meetings in collaboration with those mosque communities. And September, again, we'll be having the conference, hopefully. So some of the target mosque communities that we have been engaging were the western suburbs with MSI, North Chicago or MCC, which is today's town hall, the southwestern suburbs, so the Muslim Association of Bolingbrook and MSI, and then the southeast suburbs of like the El Nahda community. They all have different backgrounds, and we learned a lot, which was part of the PCOR principles that we were able to highlight. So co-learning, reciprocal relationships, partnership, transparency, honesty, and trust. So part of the things that we did as community health workers was speak to people in their own language. We knew them from their backgrounds. We were trying to build these honest, trustworthy relationships where they knew us and they could talk about things to us. And if I could have Brother Lot or Dr. Lot do the presentation for what the health crisis response specifically was at MCC and MEC.
Assalamu alaikum, everybody. And
sorry, one second, let me just introduce you. So he currently serves as the Health and Awareness Committee Chair with Dr. Omar Khan, and he's led comprehensive and informative sessions this past year on a lot of different community health initiatives. He works with CIOGC, Council of Islamic Organizations of Great Chicago, and has done a lot of testing drives, the flu shot campaign, and doing a great job reaching all of those people in the MCC community. This is just more about the vaccinations. They've vaccinated more than 2,000 individuals in the Elston Avenue and Morton Grove locations, and have been an excellent resource and doing excellent things. So I'll just pass it on to you.
thank you, sister, and assalamu alaikum to everybody. Thank you for making time and invitation to be a part of the program. So this last year presented MCC and many healthcare organizations and community centers an opportunity through the crisis. I think many of us were challenged with how to best meet the needs of our community while also trying to navigate our own concerns about our own health, while also trying to help others with the public health concerns that are out there. So some of the things that we did was to help provide financial assistance to the needy, primarily through our Zakat and Sadaqah program. We supported the community with food for those that have food insecurity, which is a pretty significant portion of our Elston community. We established COVID-19 testing. We had several testing drives within our mosque spaces in Morton Grove and in Elston, usually around prayer times or times when we know that many people would be trying to come to the mosque. We also established COVID-19 vaccine clinics. We were amongst the first in the city to be able to offer that in partnership with the city, also in Cook County with the Cook County Department of Public Health. And one of the necessary community activities that we need to do was to modify our approach to community activities, notably things like funerals, where we would have services inside the mosque, typically with a lot of people crowded together and serving as a source of transmission. And so we had to work with our mosque leadership in terms of modifying experiences there. So some of the programs we had through the pandemic were Zakat and Sadaqah distribution. We also provided protective equipment and education about how to properly don and doff equipment to make sure that our community members knew how to best protect themselves. We had a flu shot vaccine drive in November and October of 2020, and we're already scheduled to provide that in the coming months here for 2021. We were also in consultation with our mosque and local public health leaders on safe practices to reduce transmission. Back in November of 2021, where there was a really big surge here in the Chicagoland area, we were in consultation with our local health leaders at healthcare organizations about how best to modify prayer and congregational activities while also considering actually closing down the mosque space, which we actually did for a period of a couple months. If you could just go back just a little bit. We had to then pivot how to still provide a community space without actually having a physical space to be able to do that in. And so, like many other organizations, we pivoted to social media platforms and also in limited settings, not as a fulfillment of an obligation, but just as a means of providing community. We also were able to offer virtual prayers and sermons. Next slide, please. So impact due to the pandemic, we were unable to hold prayers for everyone. The mosque shut down in April twice in last year, April 2020 when the national lockdown occurred into June of 2020. And then again in November 2020 until almost February 2021, until the local case positivity rate dipped below a certain threshold. In-person weekend schooling also transitioned online. We are looking forward to getting that back in person this school year, which should start here in a couple weeks. We limited children attendance in the mosque space in an effort to protect amongst the most vulnerable, if you could. Protect some of our most vulnerable and unvaccinated individuals within the community. We also limited in-person education and social programming and tried to do that as much as we could online or outdoors when that was available. And, you know, with the advent of vaccines, we were, prior to vaccines, we were unable to hold our holiday prayers, notably the Eid al-Adha and Eid al-Fitr prayers in 2020 together. And so like many other mosques in the city and around the nation, we had many people did that in isolation or within their own households. Next slide, please. So some of the hurdles that we continue to face moving forward are social distancing. One of the key elements of our community activities within the mosque is a congregational atmosphere. And so there is a desire for human beings for spiritual connection in addition to interpersonal connection. And so we try to encourage social distancing as much as we can. We've taped down spaces and currently we had to reinstitute or reimpose social distancing in the course of the last month with positivity rates going up again in the local area. One of the other hurdles that we faced, like many things, or like many other organizations and institutions, is an emotional disattachment. Many individuals, especially some of our elders and our seniors, had a strong emotional attachment to being physically inside the mosque. And so it was really hard for them to not be able to pray inside the mosque. And so we had to find ways to support them emotionally, and also in increasing recognition of mental health effects of isolation. And so we tried to do that as much as we could. It's certainly an opportunity for us to continue to look at how to do that, but certainly eye-opening for us that this is a real need within our community. And I'm sure we're not the only mosque that recognize that there's a strong need for interpersonal connection, but also reinforcing and encouraging mental health practices and hygiene. There's an uneven community understanding of the pandemic. So one, is it really even a pandemic? We do have a small minority that question the validity of what's been going on for the last 20 months of our reality. But then also the benefit of vaccines, the benefit of masking, the benefit of good hand hygiene. So these are things that we had to continually sort of reinforce. And it's challenging, especially probably more so in our community within the Chicagoland area than perhaps some of the others, because we have such a wide range of people and experiences coming through our mosque spaces. We have everything from a highly educated professional class to newly immigrated refugees who may not even speak the language and have a limited sort of exposure to healthcare and people with fluency within healthcare. In addition to that, all this was all in the context of an election last year where there was a lot of politicization, unfortunately, around good science and vaccines and some of the other things that have been going on. And I'm sure many of us can probably attest to this, is misinformation from trusted sources. Certainly within our community, there's no shortage of healthcare professionals, but not every healthcare professional is studied the topic or the subject well enough to be able to speak on this. And this is also, ironically enough, overlaps with religious sort of exposure, where people have an opinion on something without having adequately studied the subject and been able to competently be able to speak to something, whether it's an infection or a pandemic or vaccines, which has been also most recently been one of the challenges within our community. So the resources that are needed for MCC are improved community understanding of pandemic trends. Nothing has been at a steady state for the last year. We've had ebbs and flows, as is, a metaphor for life. Things get better, things are sometimes challenging. And so we've had things when things were really good, initially right after the initial wave of vaccinations and before the arrival of the Delta variant, where many of us were able to actually resume almost normal mosque functions. But gradually we've had to sort of reimpose some of that over the course of the last month. And for general community members, you can imagine the whiplash and the confusion that they feel with everything that's going on around them. And so us trying to be able to be the sole voice of trust us and let us explain to you what's going on. Increased cultural competency for a diverse community. So me simply being a Muslim is inadequate for me to be able to serve the full needs of my community. I need to be able to communicate and reach both those that are American-born Muslims like myself or many of the panelists on this call today, but also newly immigrants, refugees, such a diverse range of people and demographics within our own Muslim community here in the Chicagoland area. And I really think MCC is really unique in this, in the fact that our community probably is amongst the most diverse within this city, maybe even within the country. And certainly the need for continued education and research capacity building. We're looking for moving forward some of our other public health initiatives and educational programs, and being able to communicate this to a wide range of language speaking people, in addition to increasing the understanding of how to improve their own public health their own health is certainly necessary. Next slide, please. So measures of success, this is challenging, and I think many places probably, I think many mosques actually don't really measure or have a plan for how they, a 5-year plan, like what are we going to know, or how do we know that we have achieved our goals? And this actually, is one of the things we're looking to articulate within our Health and Awareness Committee. Some tangible measures or objective measures of success would be our membership, mosque membership will have increased, not necessarily just because people have moved to the area, but because those people already here have actually become full-fledged members of the mosque. We'll look to have increasing numbers of people enrolled in our healthcare programming, and this will hopefully in the next year, we'll be able to pivot from online and Zoom to actual in-person, either outdoors or hopefully indoors as well. And I say that very optimistically of over the trajectory of what I think hopefully will happen in the course of the next year. And people within our community will view the MCC Health and Awareness Committee as a trusted source for health information. We've made some really strong strides in the course of the last year. More and more people seek us out and actually contact us for verification or validation of certain information, especially as it's come to vaccines. But we hope to continue to serve as that trusted source and hopefully for an increasing number of members within our community. And with that, let me transition back to Dr. Rasool and perhaps to the next speaker.
Right. So the next speaker is our esteemed Dr. Padella, who is an ER doctor, community health researcher, bioethicist, and the originator of this, one of the originators of this project, who has done a lot of work and is going to kind of explain, just bouncing off of what Dr. Lott has just talked about, that MCC is a really good base, and then what I've also talked about, that how we've been engaging the community and how further we can take the research and everything. He studies how, so Dr. Patel studies how religion impacts patient health behaviors and healthcare experiences, informs the professional identities and workplace experiences of clinicians, and furnishes that bioethical guidance to patients, providers, policymakers, and religious leaders. So all of this knowledge is used towards educational and policy interventions. One of the main ones that we can focus on right now is the PCOR Toolkit. So Dr. Padella, if you want to continue and go ahead and start your part of the presentation.
Should I stop sharing?
You can, is he sharing? He can share it too if he wants.
He requested the remote control, so give it to him.
Sorry, I was unable to mute myself on your screen, so you can give me back control again. And if you can make it, if you can make the PowerPoint in display mode again, sorry. All right, so Assalamu alaikum everybody. It's a pleasure to be with you all. Apologies for that short snafu there. I'm going to share with you a little bit about the prehistory of this toolkit to kind of sensitize us to where we might need to go. And I say that because you might wonder, why am I going backwards in time? I think one of the challenges that we face as a Muslim community, but also as individuals who are healthcare advocates and also healthcare researchers, is a little bit of a loss of capacity or foundational knowledge in what has occurred before. So I think it's always good to go back and think about where the masjid, particularly this amazing community, has been, so that I can address the challenges that come in the future. Said another way, from kind of the healthcare speak, we're always in a plan, do, study, act cycle, right? PDSA. And we're very good as communities to think about the planning, perhaps, and the doing, certainly. But we often kind of neglect the studying and then acting to improve the next time around. So if there is a next time around, we're now in the 5th phase or 4th phase of the pandemic, we should be in a cycle of planning, studying, and doing, right, studying what we did to improve the next response. And this is sort of the same idea in healthcare programming. So I'm going to take you backwards in time to talk to you about what has occurred at MEC and MCC over about 8 years before there was a formalized toolkit. And I'll intersperse what that led to as a foundation for the toolkit. So before I get there, a couple of, and I recognize they were a little off time, so I'm going to try to speed up, and I apologize if I want to speak pretty quickly here, but here's some background. Just a general notion of what American Muslim healthcare disparities exist is largely a opaque phenomenon, right? So this is a paper of mine where we looked at, if we tried to do a search of American Muslim healthcare disparities in PubMed, you can't find any articles, right? That field didn't really exist. People weren't thinking about Muslim Americans as a population that suffered from disparities or didn't have the tools to do that work. And if you move forward a little bit in time, there are several reasons for why that occurred, right? So one is that there's a challenge of finding American Muslims in terms of healthcare databases, right? In terms of administrative and national databases, you don't have the religious affiliation characterized with the patient population. Therefore, you cannot do research around the aggregate numbers or the issues like around cancer screening or whatever it might be with American Muslims. A part of a team that I was on tried to use naming algorithms, right? So perhaps Muhammad, Khan as a name, and try to figure out naming algorithms by which we can do that research. And interestingly, those naming algorithms have low specificity. And so that's prohibitive to use that to conduct research, again, on national databases or administrative databases. There's a lack of regional capacity to do research, right? So we all know this in the sense that, I think the screen's a little bit delayed. Well, there we go. That there's minimal community infrastructure, particularly between 3 sectors of the PCOR stakeholders, right? CBOs, mosques, and clinics. There's a lack of connectedness, so you can't come together and build the infrastructure to implement systematic and longitudinal health research. And largely, just if we're going to think about Muslim Americans, the reason you're saying Muslim Americans are American Muslims is because there's a religious identity that we're interested in. However, in the healthcare field and health research in general, there are poor measures of that Muslimness or that Islamicness and that influence upon health. Most of the measures that we have come from Christian worldviews. And when you try to apply them amongst Muslim populations, you find they don't work. So even if you had the population, you could find them, even if you had the infrastructure, then to tease out the Muslim dimensions of health and what's impacting the Muslim community because of their religious identity, it's a difficult task. So, what the solution to that, again, the screen, is just answering the first question here. Does Islam influence American Muslim health and health behaviors across race, ethnicity, socioeconomics, and geography? And if I were to say this, you would say, of course it does, right? That of course Islam impacts, but the issue is that we're largely ignorant of those impacts, right? So the Muslim community might know this, and it's intrinsically, it's intuitive that Islam impacts the way we think about our health and well-being. But the external community doesn't know that and doesn't know how. And so we haven't made that known unknown, meaning the known that we have as a community member, and haven't brought that to the market, so to speak. And that's what health research and mosques, I think, can do. So just briefly sharing with you, and for those who don't sort of know, that there is a clear influence upon how Islam impacts Muslim communities and the ways they think about health behaviors. It's an explanatory model for health, disease, and wellness. And I'm going to speed up. I'm not going to go through all these things, but there really is a God-centered view of healing. There's a construction of health, right? What does it mean to be healthy? What does it mean to be diseased? What does it mean to be well? That's all couched within religious ontologies. And there's also a construction of disease in the sense that what we should seek remedy for, all based on scriptural understandings of the maladies that we face. Islam also impacts the way in which people think about what's permissible and not permissible, right? Typically, one of the clear questions people ask is, well, can I do this or can I do that? And when they're saying that as a Muslim, it's because of they're trying to figure out whether the religious law permits something or not. So certain behaviors might be motivated and others restricted. So for an example, it would be like alcohol consumption, right? It's prohibited Islamically, and that might confer health benefits. But the other aspect of what Islam, quote unquote, has to say is that it also governs the treatment acceptance and the manner in which it is received. So an example here might be what we're going to talk about perhaps a little bit, is that porcine-based medicines are generally prescribed, right? And this clearly impacts not just attitudes towards vaccination, but actually vaccination behaviors in the community. A lot of our vaccinations today have porcine gelatin within them. right? And that the rates of acceptance of that vaccine is dependent a little bit on how you think about your religious tradition. So I'm just sharing that with you as a really concrete example that it not only governs what you can get, but the way in which you get it. Then lastly, I think all of us recognize this now, more so than 20 years ago, that being a Muslim represents a socially marginalized at-risk identity for psychological, emotional, mental health trauma, right? So some of these papers here are seminal work initially by myself and others around post-9/11 discrimination and Islamophobia. That second paper I just want to call out is the only paper that exists that shows a health impact amongst Muslim communities from the Muslim ban. The only one. And we were able to do that because we were able to get an administrative database of Somali Americans to work on. If that database was not available, we would not have been able to document that the Muslim ban actually impacted Muslim health in the community writ large. The only one. And then you can only do it because you have that one administrative database. So my point only is that this is, again, a way in which Islam impacts, or the Islamic identity impacts, Muslim American health. The question now is, where do you find Muslim Americans? And where can you get access to a diverse group of Muslim Americans, really? Two questions in one. Now, you might say we can find Muslim Americans when they go to the halal restaurants, right? That this might be a great site for research, perhaps cardiovascular research, cardiovascular health research, right? I'll say that for me, and the model that I employ is actually the mosque-based one, right? Where we can get to this religious influence upon health in a more meaningful way, perhaps, than we could at those sites of eating and merriment. So why is the mosque context very important? So sharing with you that it's central to Muslim life. And I mean, statistically, we know that in the population, nearly 50% of the community attends mosques weekly, right, for various functions. We know that there's educational, social, health, and religious functions that are taken care of within the mosque setting, as Dr. Isaac just mentioned, right? It's not just prayer, other things occur there as well. We know that the mosque is a site of identity formation, right? So Islamic beliefs and values are reinforced and taught there, right? And particularly when you think about Islamic law, what I should or can't do, this is also a part of where you interact with the religious scholars and religious learning and religious resources at that site. And really, I would argue that we call it mosque community because it's a connected community, right? It's an established social network that's centered around a physical plant or site, which is the mosque. But there are many ancillary institutions there that also play a role, like an Islamic school or a women's health health clinic or a women's learning circle. They're all centered around this physical site. So it's a huge network that is largely untapped for health outcomes research and programming. And as a researcher, I must share with you that for me, this is a testing ground by which we can assess and tease out religious influences upon health across markers of ethnicity, for example, African American, Arab, and South Asian, across suburban urban divides, and across actually theological divides between Sunni and Shia. That you can actually, if you have a large enough sample and you look at a diverse Muslim mosque community, you can tease out whether there are certain differential impacts upon different parts of the community. So moving forward, I've sort of set up for you a little bit of why, what the challenges for healthcare disparities research. I've shared a little with you about what the mosque might offer. And let me share just a couple more slides here about what presently is the state, right? So this is, I was saying, going backwards in time, but this applies even today. That generally the health culture of mosques is that they're faith-based programs, right? People will come and do screening for diabetes, right? Or for blood pressure, and that will be it, right? That's a faith-based program, meaning that the healthcare systems programming is brought to the mosque community to have a new catchment of individuals to touch, and that's it. It's a take off the shelf, bring in here. Maximally, it's often, I'm going to linguistically adapt the stuff that we have in the healthcare system and bring it to you. And it's sort of just off the shelf usage, right? And most infrastructures in the community, mosque communities, don't have much more than that, right? It's faith-placed. Just the center, the locale has changed. So instead of a clinic, we're now at a clinic and a mosque, right? We've just moved the site and the location. And the imams within this are unevenly engaged, right? So this project is an engagement project in a sense. And so the imam's role in these programs, whether they be educational or interventional, is uneven. The extent to which religious identity is brought in from the imam's perspective is uneven. Across the community, this is a study I did in Michigan, we know that imams perform several health informing roles, right? They give khutbahs or sermons that can influence the way people think about their health, right? They perform religious rituals around health and illness and dying. Every Friday after the imam gives a sermon, you have a collective supplication for people who are in the hospital. That's a collective ritual that we believe is actually a source of healing that occurs every Friday. But we sometimes don't think about it that way, but they are health informing rituals within the community, and the imams lead this. There's cultural sensitivity training. Sometimes some imams perform healthcare roles as adjunct or visiting chaplains, right, who come to the hospital system and teach the others about how to take care of Muslim patients and what the cultural sensitivities might be. And sometimes they actually prepare a more formal role and provide bioethics consultations. So this role is uneven. Each mosque is different, each imam is different, and so it's not leveraged very well. Where we would like to go is that we have faith-based programming, not faith-placed, faith-based, that intrinsically the program is crafted around a religious identity. The messages that are deployed are around that religious identity, that you're framing the health behavior within the context of being a good Muslim. And you're doing it in a theologically consonant way. I'll share with you some examples as we move forward. It's also an opportunity for addressing the religious determinants of health, right? Oftentimes in the healthcare system, we don't do spiritual histories or religious histories, and we don't ask. We just want to give you, I'm a physician, I want to give you what our off-the-shelf solution is. In the mosque, you actually think about these things in a different way. And if you have clinics in mosques, you can actually address those religious determinants of health and give tailored instructions to individuals. And lastly, you can build a culture of holistic health, right? There are many individuals, as Dr. Ishaq mentioned, who don't have the same socioeconomic access to healthcare as others do in our communities. And we can bring a culture of holistic health, address all the determinants of health in a mosque setting. And this is why it's very problematic for mosques to close, right? We all thought about, or not we, but outside observers would think, hey, you just are addressing the religious dimensions of health when you're at a mosque. But for many, it's a place of food. You're addressing that determinant of health. It's a place of social, right? So you're doing a social determinant of health. They have people ask about them. They have social networks, elderly particularly, right? That they have a social support structure in the mosques. So there are other dimensions of health that are addressed. For some, it's a clinic. That's where I get my checkups for free or my medication for free. So when you shutter mosques, you end up actually addressing multiple dimensions of health, not just the spiritual one. So as I said, I want to talk about the Mosque-PCOR Toolkit before there's a toolkit, and there are certain things that were present in these two communities, really the MEC, MCC community, that had the foundation for doing that work. So one is this pre-existing conditions, right, or the foundation. There was already a history of faith-placed prejudice screenings in the mosque. There were individuals in the mosque board who were involved. Fatima actually was involved in some of these things at those two centers. There was an active, and there remains to be continued today, co-led by Dr. Ishaq, the Active Health Awareness Committee. There's a diversity of congregations. So as mentioned by him, that there's both socioeconomically privileged and socioeconomically deprived communities within, or individuals within these two communities. And there's robust intergenerational programming. It's not just the elderly, but the young also come. There's a note of practicality and feasibility to do programming here. There are large prayer services there. Congregants are numerous. There's large classroom facilities and seminar spaces to do actually health programming in a robust way. It's not just a shop type mosque. And then there's garnered trust, right? This might be more personal in a sense, right? That my own work, my interest in these communities in 2011, 2012 was based on a personal body of scholarship within Michigan mosques, which people knew about, right? And that when I entered these mosque communities to help do health programming, I brought pilot money from the University of Chicago to set up, a foundation for research in the mosque community, and I continue to do so. And then there is also my own scholarly reputation, dedication to this notion of health determinants for the Muslim community. So that garnered some initial trust that then had to be implemented in 7-8 years of programming. So how did we engage Muslims in these mosque communities, right? So this relates to now PCOR, patient-centered outcomes research, right? Collaborative design was an operating strategy for us, right? And what I mean by that is that the PCOR principles of reciprocity, co-learning, and transparency was enacted at every convening, right? There was clearly, here's the budget, right? We're going to learn from you. What do you think works? What do we know that works in the healthcare literature? And reciprocity, we're in this together. So enacted throughout the many years of programming. We always would have a multi-sectoral and multidisciplinary community advisory board for the projects, right? And steering committees, like they would be from different sectors, not just the doctors, not just the patients, but others who would give voice to their concerns or their insights into how to make a program, as you'll see shortly. And then, capacity building is a program model, right? So you'll see here when I share with you 2 large research studies that became intervention programs, that was always about peer educator training. We wanted to bring people from the community, upskill them so they can do work in the community and continue on, right? That's even the model for this project, with the community health research workers. There's a little delay, but 1 second. Right, so, and then the other thing was replication manuals. So every project that we did has a replication manual for the community to continue on doing this work, or other Muslim communities to do this work. And similarly, in the same vein, we have community-facing dissemination products, which I'll share with you for 2 of these projects here, that are solely focused on not the academic output, but the output that's relevant, right, again, in a patient-centered way, to the community. And then, as I mentioned already, we had partnered grant proposals throughout the work that we did. So that's engaging Muslims in the mosque setting. What is the Islam aspect, right? How did we actually tease out and access the religious component in this mosque-based outcome research? Well, the study design, as I mentioned, focused on common religious identities, right? We sample across race and ethnicity to look at that. We develop and validate religiosity measures that are specific to Muslim sort of frameworks, right? Islamic frameworks, not just use off-the-shelf measures. Our data analyses, both qualitative and quantitative, honed in on those shared religious values. So we're really interested in how the religious values and beliefs impact the way you think about health and illness and what interventions you want. And then largely, in the end, these interventions are religiously tailored and centered. As I already mentioned, first of all, they're set in mosque communities, but they leverage religious theology, and the messaging is based on that, right? In a theologically consistent way. So we're not just co-opting religion, right, for health. Rather, we're partnering and thinking about how does this health behavior, vaccination, for example, how is it thought about in a religious lens, and where can we give you informed choice around that? You'll see that in my examples here. And obviously, we involve the imams and others to frame health behaviors. So to set the stage for these 2 larger projects, I know we're kind of hitting up against time. So I have about 15 minutes left or 16 minutes left. So I'm going to kind of set the stage and go through these 2 projects very quickly. But first, I just want to note, right, where the gap is, meaning everybody from the external sites, for example, as external observers in the Muslim community say, hey, well, why don't you give sermons, right, on such and such topic, on COVID-19, right, on eating healthy. But no one had done the work to think about whether or not Friday sermons were actually an effective strategy and modality for health promotion education. And this foundational work was actually done at NEC, right? So we developed some generic templated sermons with these 4 messages, right? That good health is a grant from God, body is a trust. Reliance on God does not mean you forsake healthcare or healthcare treatment. And that communities are members are caretakers of another. There should be a social component to health. So non-controversial, really plain messages. And then we assessed how the community uptook that, right? And this is the only study of its kind in the United States context. So this is a table from the paper, but I'll share a couple of findings here for you to all understand. So we just asked them about acceptability. Was the content relevant? And did you learn new content about the relationship between Islam and health? And you'll see on the right end here that almost 90% or 90+% of the population agreed with all those things, right? That the content was acceptable, that it was relevant to them, that they learned something new about Islam and health, and that they would like to see, look at the 4th one, like to see more topics, more health-based topics and sermons, right? And not only did the people who come to the Friday sermons, but they were very likely almost 90%, 80+% here, right, to share what they learned or what they heard with others in their family, right? So you're not get your quote unquote bang for the buck. It's not just the individual who came to the sermon, but those in their social circle, or at least their family circle, who they would tell about the sermon. So that's a huge sort of catchment of individuals, right? And this is the first study to show that. And by the way, we found that this didn't change across race, ethnicity, or sex, and gender. That across the board, all individuals found this acceptable. So that set the stage for a couple of interventions, and there are two I want to mention here, two longitudinal studies where we identified the issue, developed methods, evaluated the dimensions, and then designed and tested interventions. So the first one was around cancer screening. I know October is breast cancer screening month. So this is a project about, do Muslim women in Chicago suffer from breast cancer screening disparities? If so, are they related to religion? And if yes, right, can we address these religiously rooted barriers and beliefs through a religiously tailored program in a mosque? That was the question. The second project had to do with a different area, and this is organ donation. So do Muslims have organ donation and transplantation disparities? If so, again, are they religion related? And if so, can we address them through a religiously tailored mosque-based program? Right. So the same model, different question. And you'll see here the two models together. So let me start with the breast cancer one. And this was a 5-year project where we identified and addressed mammography screening disparities. And we partnered with the CIOGC that you've heard about, which is the Council of Islamic Organizations of Greater Chicago, Muslim Women Resource Center, Arab American Family Services, and Compassion Care Network. And it was sort of 4 phases of the project, right? First is evidence gathering, that we did some community-based surveys, did focus groups and community informal interviews. I'll share those with you. That set the foundation for actually doing an intervention. So we gather evidence around, is there a disparity? How do you want it addressed? Can we address it feasibly? What messages to give? That's all evidence gathering. Then we said, okay, we put it together. We designed it, co-designed it with community members. Now, did this work? So in terms of, is there a problem, right? Is there an issue? Well, here's the data from 13 plus mosques and community centers in Chicagoland, where we found that we did the survey of Muslim women. Although people had health insurance access, 75%, and although they had access to a doctor, 85%, almost a third did not have a mammogram in the last 2 years. And this is several years ago. So the recommendation for this population, these were all women over the age of 45, I think. Yeah, 45, the mean age was 52, was to have a mammogram every 2 years. But a third of the population did not, despite the fact that they had access. How was it related to religion? Well, religious discrimination, people who said they had faced religious discrimination in the healthcare system were less likely to get mammograms the last 2 years. And those who relied more on positive religious coping, which really means relying on, when an issue happens in your life, relying on God to help you more so, those individuals had a lower breast cancer screening rates. So that was phase 1. There's a problem and it's religion related. Then we wanted to understand how they think about, they operationalize religious values in the context of forming intention to get a mammogram. So this was the focus groups that I mentioned in 6 mosque communities. I'm not going to go through all this, but the point here is, again, we sampled mosque communities. If you look at the left part of the slide, African American, South Asian, Arab, right? South Asian again, and the Nigerian. So we wanted to look across race and ethnicity if they had the common beliefs, if they shared beliefs around breast cancer screening, which they did, the population did. And 3 beliefs that we were focused on was this belief that perceived duty to care for one's health, right? So this notion that part of taking care of yourself is visiting the doctor. I'm not going to go through these quotes for the sake of time. The second theme was there's a comfort with gender concordant care, again, right? So the idea that Muslim women prefer having technicians and physicians who are from the same sex. And this impacted their thoughts about getting a mammogram. Positively, if they're present, negatively, if not. And then this fatalistic notions about health, and fatalism here is much more nuanced concept than we would think about in the light of Islamic sort of theology. But this was also present. So there was a positive notion of that upon breast cancer screening, and also a negative one. Again, I'll not go through the quotes here for the sake of time. So as I mentioned, so we found there's a challenge. We found that there's religion related. The question was, can we design a religiously tailored intervention in mosques to address these? And the answer was yes, we can. And we did that through tailoring faith-based messages. So how do you do that? Well, we just asked the community, and this is patient-centered. Ask them what they think, not just we as external observers and experts in the in the healthcare system think. So they wanted to have peer educator programs. Who would be a peer educator? Someone who has got both religious and health education, right? We asked them, how do they want to have an intervention? And they suggested, sorry, the slides delayed a bit. They wanted group education, right? So they wanted to sit with other women and think about these in those circles. Then we asked them what sort of messages would we give individuals when thinking about caring for your health. And for the overarching message that they told us to give was that if you don't take care of yourself, you can't take care of your family. That Muslim women, like other communities, that they privilege others over themselves. But here is privileging myself over others, because ultimately that will be a detriment to the family if I'm not healthy. And then the other religious aspect was to reinforce multiple times that their bodies are gifts from God, and they'll be asked about that. So this duty to care for one's body. So we got the content from them. Again, patient-centered, right? Relying on their insights, not just our expertise. So we developed this 3R model, which Fatima is enamored with. So I put this slide just for her, really, just it might do something for you, perhaps not. But this model is how we tailor religious messages, and it's really important to understand that we want to frame everything in the context of a religious value system. And there are certain things like fatalism, right, that are part of a religious value system, that they're theologically true. So we don't want to address that. We don't want to neglect that, right, or say people are wrong, but want to really think about a message or messages that are theologically consistent or consonant. So here's how we address barriers, right? So if there's a barrier belief, and the 3 ways to do it. So the reframing idea is that, look, if there's a belief that's problematizing the health behavior, we want to switch the train track, like keep the belief intact, particularly if it's religiously oriented and it's true constant, right? But we want to change the way one thinks about this so that they get the health behavior that's desired. So let's take fatalism, for example. Yeah, it's true God controls disease and cure, but that has nothing to do with the fact that you will be able to find out whether you have the disease. They're separate things, right? So you keep the belief intact, but you change the way one thinks about it. So that's constant with getting the health behavior. Or you reprioritize, you show them a better train, right? So you say, okay, that's a good belief, or you don't even talk about the belief, but here's a new belief that's much better, like the belief that you have a duty to take care of your body, right? So you reinforce that belief, you reprioritize the belief so that the barrier belief is no longer the first thing they think about or the second thing they think about. Now, if it's a problematic belief, then you break it down, you reform it. You never negate it by demonstrating it's false by appealing to authority structures. So for example, if there is a religious belief that's theologically not accurate, you would bring in a religious authority to talk about that. Now recognize that this is perilous because there's a lot of polarity within the tradition. So you have to be really sure that's what the community wants to, that's what you want to do. And that's, if there's a belief that's totally out of bounds, but that's the perilous notion. And you could do that in certain cases. Okay, so that's the 3R model. And then what ended up happening is we leveraged all these techniques to have an intervention. The intervention, again, was at MEC. And we had a workshop on women's health where we had a peer education-led program, which involved expert-led didactics. So there was a religious scholar, female one, speaking about relationships between religion and health, a female breast surgeon talking about the importance of mammography, and then we had a community organization talk about healthcare access. And let me just share with you what ended up happening. This is just some background here that we had 52 people in the intervention, largely Arab American and South Asians, because we did it in different mosques. That's the age range. And you can see that some of the predominant group was those who are on the socially, economically sort of deprived side. But what ended up happening through this program was a two-session workshop over 2 weekends, was that their likelihood to get a mammogram changed positively. That's the 0.29 here, pre-post. And after 6 months, their confidence in getting a mammogram also increased. When you think about these sets of facilitator beliefs that would promote getting a mammogram, that increased after the program, right? And their knowledge about mammograms also increased. So not only was their knowledge increased, the belief structures changed positively through the 3R model. And then did they actually get the mammograms? That's also true, right? So you could only be enrolled in the study if you hadn't gotten a mammogram the last 2 years. Within 1 year, we had half the group got mammograms. And then, as I mentioned, we did community-based dissemination projects, right? Products. So we actually had developed a video. There's a tailored video talking about the beliefs that we found within the community that describes, right, this context of getting a mammogram. and what Muslim communities need. And this is directed as an outreach to healthcare systems to be more culturally sensitive, right? So there's a video there. And then our work was picked up by Newsweek and others to try to replicate the program in other mosque communities around the country. So I said the other project, and it's a similar model, so I can be a little quicker here, was around organ donation, right? So this is formative research that I did and my team did years ago, where we looked at what are the attitudes towards organ donation amongst the Muslim community. And this first study showed that amongst some Arab Americans, that 35% held that deceased donation was always justified, meaning the other 2/3 did not, right? Or were unsure. And Muslims were less likely to support donation. And in all mosque sample of Muslims, this was same true, right? 39% supported deceased donation, a very low percentage, and more than half believed it was not ethically justifiable. So that's the kind of the backdrop on this negative sort of or unease with organ donation in Muslim communities. If you're thinking about the Islam factor, we know that this is a work that I did from a normative lens, that there's inherent plurality within the tradition. There are 3 dominant positions around organ donation. That's generally impermissible because it violates human dignity, all types. That it is impermissible in principle, but it's conditionally permitted because of the need for it, right? The dire necessity, people are dying. Or the third, that's permissible, generally speaking, but has several stipulations that must be met to keep it permissible. So that's the religious law, right, around organ donation. So there's plurality. Each one of these is defensible and justifiable from within the tradition, and actionable from the basis of people's behaviors. But religious permissibility is not the only concern. So this was a study, again, through MCC and MEC around Muslim women's organ donation beliefs. And so there are other concerns. For example, how is my body treated, right? There were questions about religious modesty being met if they were to donate, living or deceased. And that's not just a religious concern. Are they morally culpable for the deeds of the recipient? Do they have to think about who gets their organ because they'll be at the end of times, right, on Judgment Day asked about it? Is brain death, right? Is it a legal death or is it a dying state? Because this impacts how you think about living in deceased donation. And then this larger question, right? Why is society neglecting other solutions, right? Prevention, right? We can't afford giving people hypertensive medications, yet we can afford getting a transplant, right? Xenotransplantation, there are animal models, and then synthetic organs. So this drive by society to quote unquote harvest organs was one that was repudiated by some members of the community. So again, it's not just religious permissibility, but other concerns that came in. These are the beliefs that you have to address within the context of an intervention. So we ended up doing an RCT, right? So the breast cancer work was an efficacy trial. Here we actually did a true RCT where we had mosques in Chicago and DC, 4 mosques, and we did workshops on end-of-life care and organ donation with the goal of seeing whether or not people increase in the knowledge and behavioral intent towards organ donation. And really our desired super outcome, right? The meta level outcome was informed decision making. So here's the results, right? So as I said, I'm going to spare you the details of the intervention. It was similar to the breast cancer one, which is religiously tailored using the 3R model. So knowledge increased, right? So biomedical knowledge of what organ donation is and what it entails increased across the sample. Increased Islamic knowledge of organ donation. So those 3 rulings, as well as the ancillary conditions around them, people increased in that knowledge, as well as end-of-life care. So we had a dummy workshop, so to speak, which is end-of-life care around brain death and other things. That knowledge also increased. So both arms was beneficial. Intentions to donate also increased, right? So in the sense that people hadn't thought about organ donation, they now had moved towards organ donation. Think Q to action. People were not prepared to make a decision. They were now prepared, and people who were extremely unlikely to donate were now likely. Now, our goal wasn't donation. Our goal was informed decision making. But once you got rid of the myths and the barriers, or at least demystified them, people thought perhaps this is where they find themselves in their tradition, that they want to do that. And those who had increased biomedical knowledge also increased in their preparedness to make a decision. And then it's all about community dissemination of products that are valuable to the community. So in those workshops, we actually had these lists that people come up with pros and cons in group settings. We used all that content to create a tailored brochure around organ donation for Muslim communities, which walks people through this decision, right? Where you have to get some medical basis for that, right? So what are the medical considerations in donating? What are the religious considerations with all the opinions there, right? And the basis for that. And then, right, someone who wants to donate, what can be donated? The medical facts, right? What can be donate while you're living? What can be donated if you were to pass away? What the myths and facts are around those things. Again, the beliefs, and they brought them in. And then the end of the pamphlet is around what's right for you. And here's a decision tree. So the goal again was not to make people, and it is not to make people donate, but it's rather to help them make informed choices based on both the religious knowledge and biomedical knowledge. So now this is my closing slide. So I think I've caught up in time, almost caught up in time. What are the challenges for mosque-based PCOR? We're going to talk a little bit about this, and I'll have some questions for the panelists. Right. So from my perspective, as one who's been doing this for now 10 plus years, is sustainability really, right? Largely there's fiscal sustainability. When a grant ends, the program ends, right? So we're talking about a preventative program, for example, a breast cancer screening program that was proven to work in the MEC, MCC community and other mosques. But as soon as the grant ended, right, or do we have communities to take that over and partnerships to take that over? That's a question. There's infrastructural challenges, right? So who's going to own that intervention program, for example, right? As I mentioned to you, one of the biggest challenges that this project is trying to address is make more connections between community health organizations, healthcare systems, and other partners. So you have this connectivity that you all can work together. I think that's also a challenge for sustainability. Mosque leadership changes rapidly, right? And then the priorities change. The new president comes in, new priorities, right? New health committee chair comes in, new priorities. I think that's a challenge for sustainability, both from a research lens, but also for the healthcare partners, right? They don't want to be changing and thinking about a new person all the time. They want the sustainability because projects and partnerships take time to develop trust. And if you have new leaders all the time, then you can't develop that trust or that programming. As I mentioned already, there's a lack of connectedness to healthcare systems. The other question as a researcher here for me is cost effectiveness, right? So we move from projects to programs. And part of this dissemination in Mosque-PCOR Toolkit is at the end of the Mosque-PCOR Toolkit, we talk about how to make things sustainable, is to embed community health workers within mosques that mosques pay for and healthcare systems partner in paying for. Because that way you have it's consistency of programming, right? So that's a challenge for us to think about sustainability. And generally speaking, there's high rates of participant attrition within any programming, right? Which you have to address. So the question for all of us is, what is the future of the Mosque-PCOR Toolkit? As I mentioned to you today, I didn't want to go through all the levels of the toolkit. You can get that online. And this community that we're talking about today is much more sort of high level involved past just the rudiments of the toolkit. It's what are we going to do in the future? And so our panelists are going to be discussing this, or helping us discuss this in a few minutes. So I'm going to stop. You wanted a break, Fatima. I have seat control. I did my best to get us back on time, and you can take us from here. Sorry, you're still muted, Fatima. Fatima, sorry, we can't hear you. You're muted.
Oh, thank you so much for the wonderful presentation. Over the past 10 years plus, more than a decade worth of materials, literally sweeping in less than, in 30 minutes or so. It's tremendous. And I just want to point two things there. Number one, that the 3R model is really more of a communicative model that came out from your research. And the other thing is the informed decisions and the science of informed decisions and how you have broken it down into the pieces at every level. Instead of having a confrontational side with the patient, you're literally taking the hand and taking the patient step by step to the other side. That's amazing. And I think that's exactly what we are trying to do using the Mosque-PCOR Toolkit to support the community health worker program to move it forward from that point on. I do see we don't have all the panelists, unfortunately, with us today, but however, we have two of the most important panelists, alhamdulillah, Rochelle and Wana. And I want to perhaps give the control back to Javeria a little bit so that the panel can be more open and discussion. Would like to hear a lot from people because I'm a talkative person and I talk till the time comes at, till the end. So Javeria, why don't I give you back and you would like to introduce both Rochelle and Ioana. And we will ask, we will have specific questions for them and the panel discussion will be open for everybody.
All right, I would love to. All right, next slide. So we'll start out with Rochelle Paul Brutus. She's the coordinator of research and evaluation for the Chicago Department of Public Health. She works as a liaison between academic, community, and city partners to develop and support partnerships between the community stakeholders, research and evaluation partners, and to build that community capacity for research question development and facilitate dissemination of those research findings, which is so key for this discussion. I'm so excited to have her here. She also serves as the co-chair for the Chicago Consortium of Community Engagement and represents the health department as a key stakeholder meetings on community engaged research.
I just
So
want
welcome.
to, I just want to add that Rochelle is actually part of the team that led the development of the report for the life expectancy, where this idea came from. Where that actually changed the entire Department of Public Health, Chicago Department of Public Health last year, and the way they look at things, the way they do things, how the funding is done, how the priorities are set. So it's a phenomenal piece of work that came out and a beautiful report. And we will be sharing that with many partners across our communities as well. And perhaps going on with several discussions around that report. And again, Javeria, back to you.
All right. Okay. And then our second panelist today is Juana Ballesteros. I'm so sorry if I said that wrong. She is Join Now POW, a woman-founded and woman-led tech startup that e-prescribes community resources to meet both the health and social needs of people. She plans and implements strategies to build and grow networks of a community level health and social services, fosters the sustained partnership engagement to grow and support those strong referral systems to help people get self-care resources that they need. She has so much experience in healthcare, nonprofit, and state government, and a deep commitment to addressing racial and ethnic disparities in our healthcare system. And she's also worked with the Illinois Department of Public Health, instructed students on critical public health engagement as a professor at Northwestern University's Feinberg School of Medicine. And her expertise is in community development, program implementation, and strategic partnership has served her well in her previous roles and her current role. And I hope today will be an excellent resource today for us as well in this panelist discussion to answer some of our questions. She also holds a Bachelor's of Science in Nursing and an MPH with a concentration of Community Health Sciences from the University of Illinois of Chicago. So welcome to both of you. I think our other.
And I just want to add one last thing for Juana. Juana actually led the efforts for the community health worker trainer program and the recommendations that came out from IDPH a few years ago that has led to signing off the legislation by Governor Pritzker earlier this year in April. And because of that legislation, community health workers will be paid by payers and by hospitals. So it has now become a discipline. So the next level in this community health work discipline would be workforce development, and we would see actually we would then see many people getting jobs as certified community health workers. So it's a huge step in the development of community health. And I think between Rochelle and Juana, this is and with this research, it's a beautiful platform to discuss sustainability for these kind of research projects. Okay. One of the person I want to say that is really missing in action is our patient partner. So that is in fact, patient partner has been missing throughout this entire project. Nobody is willing to come out and say that from our community, at least, that yes, I am a patient partner. I will be the voice for that patient. When it comes to patient, the community often thinks that patient, you're not talking about me. So we left it at that. That's another research project for Dr. Patela to figure out where the details are for that. And we're going to move on with what we need to do as the grassroots level. Okay. So here we are with the first question, that how can we make partnered mosque-based health research interventions program sustainable? So we would hear from Juana and we would hear from Rochelle. Go ahead. Who wants to go first?
I guess I could kind of get us started. As I was, thinking through this question earlier today, and this was mentioned, in the previous presentation, which is really wonderful, definitely very comprehensive from beginning to end. I go back to, a data, right? And again, this was kind of really emphasizes like the lack of data, right? And, I think back to, race and ethnicity data from like, the census down to even local municipal data, right? And so, I myself, I'm a daughter of Mexican immigrants. My parents immigrated to this country in the early 70s. And, just until recently, we the race, the options for race, I could not identify, with any of them, right? And I would leave it blank many times, or I would write in, Mexican American. And now recently, and we all know that, that it's not we're not a racial group, we're an ethnic group, right? Because there are Afro Latinos, there are, and everything in between, right? And so I go back to, how can we, make a case for something, right? For a research question, a research intervention, programming, right? Prioritizing funding for a service when we don't have the data that accurately represents what the issues are, right? And so, to me, it takes a step back to like, and I'm not saying we should ever wait for government, right? To make a category for any of us, right? Whether, we should advocate for that with our, with our local leaders, and then on our own through our programs and services, our local community-based organizations and local faith institutions, document that information, right? Again, not waiting for government. And so for me, it's like having the data that tells a compelling case, right? For why certain research question needs to be answered, why a certain program, intervention is necessary, right? And I think in having that data to then, once a research project is implemented, once an intervention is implemented, using those same data indicators to kind of monitor, right, the interventions and the research, and ultimately to evaluate, right, effectiveness, right? And so for me, it, and to me, that's all tied to sustainability, right? And so to me, like data, and I am not an epidemiologist, I am not a biostatistician, and actually math was not one of my more favorite subjects growing up. However, I have learned to appreciate data and data sets for what they tell us, but for what they don't tell us, right? And that's when we need to start to challenge, those bodies, those institutions that provide data, to really capture all of the different subgroups of individuals that make up our communities, our state, and our country. So that's my immediate thought on that question.
Great, Rochelle, you have more to answer. Oh, let's actually, yeah, you have much more to answer than just this question now.
Uh, well, I will add and again, thank you for inviting me to be part of this conversation. Truly appreciate being among, all of you this evening. And I will piggyback a little bit on what Juana just said, because yes, in order for programs to be really significant, one is the data that is being produced, because without data, sometimes it's really hard to see, especially for funder, for them to see if it's worth for them to keep funding that same program or not. And I will also add to that, like, and particularly in the role that I that play in the health department, I feel like a lot of time for those programs to be sustainable, the community who those programs are made for have to be involved from the beginning in the program, in the sense that being involved is not just being recipient, but involved at the beginning with the design, the implementation, and the dissemination of those interventions. Because once you get the buy-in of the people that these programs are made for, then you know that they're gonna be supportive and help advocate for them to remain active, as they know that they are something that is beneficial for them. Another thing that I would like to add, and also Juana mentioned this, is like evaluation, because sometimes having program just for the sake of having program may not be something that people want or funders want to see, because you want to see that the program that this intervention are targeted to are actually having the desired impact. So having the making sure that you have an evaluation component to all of those programs will also help funders to know, like, hey, this thing is really working. Let's continue to fund it, and let's continue to encourage this type of intervention. Another thing that I would like to add, because I like the part of the question that talk about partnering, and once we partner with either mosque or academic partners or researcher, have those partners looking for funding together, because oftentimes our research partners have like maybe more experience to look for certain type of funding, or writing the grant, know the language. So helping the partners, being at the table together to seek funding, to make sure that in addition of a successful intervention, there's the funds behind it to make sure that this intervention remain successful for many, many more years. And the last thing that I will have to add is that, when you have like a program like this, making sure that the data, the result, the outcome are being shared different platform, because oftentimes the platform used for dissemination might be very local, but it's always good to involve other agency, other partners, other organization, because by having more people involved in the sharing the information, that also open more opportunity for funders to see the great work that is being done. So this is in a nutshell when I put my thought together, what I am thinking about this question.
So a couple other questions that we put together, that what are the priority areas to reduce the life expectancy gap among Muslims from your perspective? And this is a question for Rochelle.
So for me, when I saw that question, and I cannot talk specifically what will be the priority area just for Muslims. I would just get it a little broader, because when I think about life expectancy gap, I'm thinking about what the health department put in terms of the drivers of the life expectancy, which are the chronic disease, homicide, we have maternal and infant mortality, infectious disease, and particularly now we're talking about COVID, we have the pandemic that we are all facing, and also opioid overdose. This is the priority, the drivers that in our Healthy Chicago 2025 plan that we have identified have been among the main drivers for the life expectancy gap. But I will also encourage people to look at our Chicago Health Atlas, which has a lot of data that are being displayed per community area. And then by looking at the different data being displayed in the atlas, you can see like the data for a particular community compared to Chicago, and see the percentile of where this community area fit compared to the rest of the city. So that'll be another area I will encourage people to explore, because the data that are being put there, but we have a lot of data around those 5 drivers that I mentioned earlier. And another thing, since we are still talking about data, is really helping community be more familiar with the data that are being publicly available to them. Because one thing that, and I know when I talked a little bit about it before, data is really the visual that we have to help people to help increase awareness about certain issue. And when we look at those publicly available data, we can see, particularly in a community area, like where this community fit compared to the rest of the city. So I will definitely encourage people to look for that, but also encourage people to create their own data, because as you guys are developing this toolkit, I mean, I don't want to say developing because it's already out, but as you guys continuing to put those research activities together, starting to create a database that can be hopefully be displayed on the Chicago Health Atlas, where other people can see this is the type of data being collected, particularly for our Muslim community. So
Thank you. Yeah. So, what you've just said and what Juana was saying earlier, I see that there is a need, there is a gap where the infrastructure to collect the data is actually missing.
Mhm.
Any ideas, Juana?
Yeah, the other thing too is, as I was reading these questions earlier today, is, sometimes you need to really hold, whether it's elected officials accountable, individuals, in government roles, to one, I mean, increase their awareness, right, about, and especially if these are individuals, elected, individuals who represent, maybe the districts, right, the actual districts where the community lives, right, knocking on their door, I mean, virtually, obviously, because we're still in a pandemic, but nevertheless, making them aware of what the issues are, right? You are constituents, and these people are held accountable to, you should hold them accountable, right? And so I think the more you can make individuals who have that power, to make a change, increasing their awareness and holding them accountable to have the political will, right? And really, it's communication, it's ongoing communication, how it is. Many of you have been leaders for many years, right? And so to me, that's a very critical step, right? When, especially right now, Fatima, when you said there's just the infrastructure is not there, right? And how do we get the infrastructure, right? I see several doctors here. I'm assuming there is some connection to larger health systems that some of these doctors have. Our alma maters. I studied public health, right? And so, the schools that we graduated from, what are they doing with regards to, their research, right? I went to UIC, big research institution, right? And so what are our, alma maters doing about research and data collection and reporting, right? And so I think also too, not just looking to government entities, but what about the local academic institutions, right? That we know are doing research. are collecting data, right? How do we hold them accountable, right? To be more responsive to your needs, right? Are some of the things I think about is like, let's hold people accountable, right? I think could be very, very fruitful, definitely.
And if I
And
may-
I would just add too, if I may, you know, the second question here, you know, and Rochelle, you know, mentioned this, and then I love this religious determinant of health, right? Because we always hear about social determinants of health, right? And so I think if we're going to reduce the life expectancy gap, I'm all about what are at the, you know, so we can say, you know, more African-American women are dying of breast cancer when compared to, you know, their white counterparts is one good example, right? But it's like, what's really at the root cause of that, right? What's going on? African-American women, you know, their DNA is, they don't have a different, you know, gene that's putting them at higher risk, right? It's an issue of access to quality mammograms, access to quality follow-up, right? When they have abnormal mammograms. And so I think when I think of the life expectancy gap, so let's just use, you know, obesity for another example, right? Is it, you know, telling people they need to exercise more, but yet they live in a food desert, or they work a job, they work 2-3 jobs to feed their family. So how do we get people more living wages, more, you know, making sure they have access to free or, you know, low cost fresh fruits and vegetables and other healthier foods? So I always want to challenge myself and challenge others that when we talk about this, let's really look at the root causes of these health disparities and really tackle that. And in doing that, you're really going to make that like deeper, long-term, you know, impact, right? That's not so temporary. So I challenge us to also, you know, do that.
Yeah, so you brought up a very unique angle that with respect to infrastructures, and I personally have not really thought through that with the food deserts that exist. Let's hold the public officials accountable in that communities for that particular social determinant of health. That is definitely an angle. I want to hear from other panelists, other attendees, and I'm sure there are questions out here. And Brother Dr. Lath, if you like to have any questions and you want to add more to any of these questions or answers.
Sorry, was it for me?
Yeah. I was wondering if you want to add to these questions or answers, or
No,
have
absolutely. Inshallah, if there's a question that I can help with, please let me know.
So you have done programming in your mosque community, and given the depth of what Rochelle has mentioned and what Juana has mentioned, what do you think that MCC would it be most beneficial for MCC that they can help?
I mean, I think one of the definitely encouraging education in a social perspective. You know, I think Dr. Padella did a really nice job of trying to reach people where we are. We're trying to reach people where they are, and where they are is in the mosque for Friday prayer. Trying to create a separate program that's during a weekend or an evening is really challenging. And so when you have someone who's speaking from the pulpit, who is a religiously ordained official who has authority and has credibility with the social community, that's probably the best place to start and at least introduce the concepts of being good stewards of your own health and the health of the community in general. And from there, we can look to build off of other programs, whether it be testing or screening prevention, or any one of a number of other things that would benefit. But that pulpit is a monopoly that is different, that is distinct within our community, that no other sort of venue can really challenge. All eyes are tuned in every Friday between the hours of 1 to 3 p.m. here in the Chicagoland area. And so that's a good place to introduce the need and the emphasis of taking care of yourself. And hopefully we can build programs and other activities around that time. we're looking at establishing, for example, we established our COVID vaccine clinic after Friday prayer because we knew people were coming to Friday prayer. So it was easier for them come, spend 15 minutes afterwards, get themselves vaccinated rather than coming on a Saturday morning or Sunday morning. And so trying to leverage where people are already going to be at and trying to build programs that are linked to that are probably the best approach.
Mm.
Okay, I had a question slash comment. So when it comes to the infrastructure and the getting the policy makers to pay attention, is that more, should we be coming more from like the leaders, or should we get the community members more involved? Like what would be more effective, or what would be kind of like the approach to that?
You know, I asked one of our mosque leaders, and this might be something that is possibly, there should be some objective data on this. I wonder how many mosques in the Chicagoland area or places of worship, churches, synagogues, have a health committee. And from that, how can the health committee be connected to faith-based programming in an effort to connect the faith activities that are going on in the community center with the healthcare activities and the emphasis on other healthcare activities that need to be completed. So I wonder, Sister Fatima, if you know, do you know how many mosques in the Chicagoland area even have a health committee?
So before I answer that question, I got to tell you something about Pastors for PCOR. Dr. Rebecca Johnson, who have been a part of our co-I on this one, and she's has helped us develop this community health worker program from the religious perspective. She actually has been a part of Pastors for PCOR, an organization that's attached to Bishop Gordon's churches, and it's headed by Dr. Paris Davis, and they have actually done it relatively successfully in their community. However, they have been working in their community for the past 8 years. So it has taken some time to develop the capacity, but they have been very successful at this model. So yes, I do have some of the major mosques, actually, Brother Saflab, going back to your question. Just a thought. So I would highly encourage people to Google P4P or Pastors for PCOR. There's a lot of literature available online, and they are involved with quite a few PCOR projects. So please follow them up, and they're doing some phenomenal work in the communities. Going back to your question about how many mosques, yes, pretty much all major mosques, major meaning the mosques with congregations of 300 plus, they all have a health awareness, not technically speaking, a health awareness committee as a funded piece of their board, but have somebody who heads up those initiatives. And I would like, I know Nancy has some questions. I would like Dr. Johnson to say something about the question that you have posed. Actually, in fact, Dr. Rebecca has a very interesting question. I know Nancy has some questions in the panel, but while we are discussing on being on the topic, so Dr. Johnson is asking, Dr. Patel, what do you think are emerging as the conditions threatening life expectancy amongst Muslim population going forward? Dr. We can't hear you.
Sorry, so
That's okay.
you're asking me, and I was just thinking for a second how to answer that, given that I know we need data. You heard both panelists saying they need data, and you heard me saying that we have challenges to get data. So I was thinking of whether I should pontificate or should tell you that we need data. So I'll answer this in two ways. One, that everything that occurs in society, it's not like Muslims are oblivious to that, right? So if there's a societal problem in cancer, if there's a societal problem with COVID, it's not that the Muslims are somehow an enclave that's protected from all the other determinants of health that are affecting us. The ways in which those affect our community might be different. And that's what I sort of suggest, that we have to be careful to not assume that the same ways in which the problems are affecting others are affecting us. But unfortunately, and this is kind of my question, and putting it back on Juana and Rochelle's, plate, and not their plate, but the larger collective, right? That there is no way for the health, the healthcare community does not collect data on religious affiliation. So to put the onus on communities that are marginalized, say Nigerian or Somali or Rohingya refugee community, to come up with the data to say, hey, there's a problem here, I think is a problem, right? For an under-resourced community, maybe not MCC, but say, show us that there's a problem, and then we can potentially address it, is kind of putting the onus on the patient, right? To determine that they have a problem, and as opposed to the healthcare system to come meet their needs. And I'm not saying you're saying that, but it feels that way a little bit, given that there is no way for me to change the rulings, the legal statutes for how we collect census data, right? There's no way for the community to develop a robust healthcare infrastructure and have a NORC, right, National Outcome Research Center, which is at Chicago. It's a multi-million-dollar budget a year. There's no way any mosque would have that just for health research. And so we're limited in that way. So I think that we can say, yeah, if there's the 5 leading determinants of mortality in society, Fatima, also affect the Muslim community, but the way to address them might be different. And the only way to address them in ways that are actually efficacious in the Muslim community would to do research. And to do the research, you have to have resources and funding and complementarity between the healthcare system that's interested in serving the community and the community themselves who are invested in understanding our own. Invested is, I'm using that term particularly specifically, invested in figuring out how we can also partner and address these and tackle these life expectancy gaps.
And
Sorry.
if I may add, Dr. Padilla, I'm from Haitian descent, so I'm Haitian, and the same way that you explained that the lack of data, we also as a Haitian community are facing the same way, the same challenges. And one thing that few of us have decided to do is just, starting those conversations, because I recognize that whenever surveys come out, demographic, they only listed a certain category of demography, but they don't specifically have, and I'm starting to see it as survey in New York or Florida, when they have like a high concentration of Haitian, when they will include in the demographic component Haitian or Haitian American. And I think those groups, have started those conversations at the community level, saying like, well, we need to start being represented, because compared to a lot of people, and I know my EP at work always giving me a hard time, I never check African American in a survey, because I don't identify as African American. I don't identify by just Black, but I always have other, and I put Haitian American. So that's how we have started to do. And I know the EPs at my job are like, why are you doing this, Rochelle? But because that's how we need to start making them realize that they need to add more category in their demographic question, And also, again, talking about the life expectancy priorities, not everybody's, it's not a one size fits all. So not everyone has the same issue, the same challenges, because being Haitian, we have a language barrier, we have culture, we have all these other factors that make prevent us to strive at other communities. And that's why we have decided, it's also small scales now, but starting to take this matter in our own hands, to start creating our own survey. It's a small survey when we're asking people, hey, what are some of your health concerns? What are you going to the doctor for? And with that small survey, we partner with a team at the University of Chicago, because we wanted them to have, Haitian translator when they go to the doctor, because people will not go to the doctor because they could not find translators, and therefore their health needs were not being addressed because they didn't have the appropriate resources just going in a healthcare system, for them to get the help that they need. And I know this is small scale, but this is something that a few of us have started because we want to make sure that, we want to start being counted, and we start talking with other groups in our community that when the census come, we need to start putting, who we are for us to start being counted. And we're hoping that the more people get on board with this initiative, the more, Illinois, we start recognizing that we need to have more option for people of Haitian descent, for example, and then for them to start looking at the data differently and making sure we are included. So I'm sharing that story to say that it's not going to happen overnight, but it starts by a few people that are being concerned about making sure that they are being represented. And then I know it's a lot of work and it will demand down the road resources, but we are very excited that we were able to partner with a group at University of Chicago who are open to work with us on that, and we're hoping that the more we can increase awareness, hopefully we can have elected official and other entity decision maker want to make sure that we can be added. So this is sharing that story to say that I know it will take time, but it's because the data, the surveys are not designed to include specific ethnic group, but by us putting our head together, we should force them, like state like New York or Florida, force them to start recognizing that there's a group that need to be counted and counted as Haitian and not just part of the African American pool. So I just wanted to add that.
Amazing, amazing example of Rachel.
Yeah, and I would just add, and apologies if that's how I came across. I didn't mean to come across like the onus is on the community to collect its own data to then present to, policymakers and decision makers, right? What I was trying to communicate is holding those people, accountable to, right, to start to collect the data for different, racial ethnic groups, subcategories of racial ethnic groups, right? And since, and a great example was just given, I'd like to give another example that happened because of COVID. Everyone was interested in, obviously before vaccines, what was the impact, right? What were the disparities, right? Was COVID impacting certain groups more than others? Why is that, and then when the vaccines became available, who is getting vaccinated, who is not, right? To really inform outreach, tailoring messaging, right? To hopefully increase uptake of vaccines. And so, the leadership of the Arab American Family Services, I hope I got it right, they really push the governor's office to say, hey, there is, we're kind of unfortunately being lumped if we answer the questions into the white category. Fast forward, they email the governor's office once, twice, and then actually at a press conference, they actually were able to get a local news reporter to kind of pick up on this. And this news reporter asked the governor during a press conference about this. He said, we're, definitely looking into it. A few days later, you go to the IDPH website and there you see, I think if I got this correctly, the category of Middle Eastern / North African, and so it's the power of again, people, using their voice to say, hey, this isn't right, and trying to hold, in this case, the governor of the state of Illinois accountable. And so I think that's also a really great example, right, of the power of people really advocating.
I would like to ask Dr. Johnson as to how, knowing her background in PCOR, how does she think that PCOR would help develop the infrastructure that's kind of missing, and these gaps that we have in the communities, and to push in the direction of more data gathering for better research questions.
Is there a way to unmute Dr. Johnson, because she's on the
I think
attendees list?
Everybody people they can unmute themselves.
No, no. Yeah, she can.
Oh,
mute
go.
herself.
Can you hear me now?
Yes.
Oh, that's great. Sorry, I'm on my phone. So Fatima, sorry, can you say that
Yeah,
again?
because there's only 2 attendees, but anyway.
Yeah, we can hear you, Dr. Johnson.
Okay, so what was the focus? What did you want me to sort of?
So I was given this gaps that we have, and the need to build this kind of infrastructure within the
Yeah.
communities for more data gathering. How do you what and you have a long history with PCOR. How have you accomplished this, or what are some of your ideas on this?
So no, it's a very interesting problem, and I just wanted to give a shout out to Rochelle, actually, because she and her co-authors at the Department of Public Health have actually published a report called "The State of Black Health in Chicago," where they actually wrote a report which was highlighting all the data about Black health. And it's an interesting question, because I was wondering whether other groups would appreciate that too, and that's why I was wanting to sort of perhaps get a conversation about that, because when I'm a gerontologist, so I study older adults, and the city also produced a wonderful report which was highlighting data for older adults. But one of the issues about older adult research is it doesn't really talk about diversity. So a lot of the policies tend to be very focused on white experiences, and a lot of the research is focused on white experiences. And when we were talking about the report at a conference I was at, there were a couple of ladies in the audience who were Spanish speaking, and they said that they would really appreciate a guide to the experiences of older adults in Chicago who were Hispanic or Latino. So I was wondering, I would love to see that happening. I think, but I wanted to ask whether that was something that people would welcome, because you also see this with HIV and AIDS research. It can become very focused on quite on particular numbers, and that in itself can be an issue. But I would love to hear people's perspective on this, whether or not diversity, focusing on particular ethnicity is useful.
Good evening. Did you ask to unmute me?
Yeah, if you can talk.
Yeah. Go ahead.
Oh, no, it just said that the host wanted me to be unmuted, but I had just put a question.
Oh, sorry. We're making sure that everybody is unmuted, or we haven't accidentally muted anybody.
So I think that's one way of doing it. There are other, as you were saying, Fatima, earlier as well, faith-based communities are actually very good at sort of spreading, that they have wider geographical spreads. So for example, Pastor Sufiko, Bishop Gordon is actually in charge of 44 churches, 44 Baptist churches. And so across the city. And so you get different types of groupings. And I think that's another way of doing it. So it really is a question of how people would like the data to be clustered as much as anything, I think.
I know Nancy had several questions and we're almost up our time, but Nancy had several questions and been wanting to.
She can,
Oh, thank you. Can you hear me?
Yeah, we can hear you, Nancy.
Well, I think my questions I've been addressing to specific panelists, not to diverge the conversation as things come up. There's so much going on right now. But I also, of course, want to put in a plug for faith community nurses, and Muslim faith community nurses particularly are new to the Muslim community. And I've been working, pedaling like a duck behind the scenes, and I'm almost ready to move forward with that. I am moving more slowly than I thought that I would, but I understand that the funding available for community health workers is the same funding that possibly may be able to fund faith community nurses. My concern is that faith community nurses, even in the Christian community, are not inclined to accept funding through avenues that would dilute their purpose of holistic health. So there are Christian faith communities, many of them who practice on a voluntary basis. And my feeling is, as I talk to people in the community, find nurses that want to be funded. They may want to serve the community for the pleasure of Allah. And my dilemma is that in putting them in place, it's more difficult to keep them accountable to the scope and standards of practice which are in place already for nurses in this setting. And so it's just something that, inshallah, if it's meant to be, that will. And I keep kind of moving forward in the face of understanding community health workers are also moving forward. So I think that there is definitely so much work to do, that there's room for both. And the thing too that I have realized is that for the Muslim community coming to their own in the American society, everything is just exploding with opportunity. And the young adults who are Muslims are highly educated, highly motivated, and many of them are funneled into that, either become an engineer or a doctor. So those Muslims who want to be doctors are also eclipsing my efforts. And so to try to find a place for an interdisciplinary model within a mosque is, I still believe, the best model. I've come to believe that preventative health, the community is not quite ready for that yet. They don't understand the concept. And to try to put a nurse in a mosque setting, I've been doing it. I've been making inroads for years, but I find that I have to go through a clinic to access to people. They call me all the time, but they always say, I know you're not in the clinic today, or I'm calling you because you're a nurse and that's what you do. They don't yet put the pieces together that is my role. And so to have role clarity, I think, is really important, because we have this rare opportunity to really establish what it's going to look like in the community in the best way, to set the bar in the best way. And there are plenty of models in other Christian denominations of things that work and why they work. And I do believe with the present status with COVID, post-COVID, trauma, what the mental health and everything, I think there's room for a nurse, a social worker, a physician with oversight from the clinic perspective, and community health workers to reach those marginalized populations within the community, because within each community, there's marginalized populations within that diverse setting even. And so I think we're making great strides, and my ability to establish a health committee preceded COVID by many years. And I couldn't get it to stick because people in my community, like many Muslim communities, are not used to structure. And I am coming from an American mindset. So I have to go with how, because I don't feel like I am in a position to say this is how you should do it. I think integrative approach is really important, but to see how it organically develops from within the community, and COVID has pushed it all forward. So now we have this fabulous IFN COVID task force, which meets regularly. People take it seriously. People are invested in making it work. And so now making that transition from just to focus on COVID to healthcare in general within the mosque, but not having health be the entire focus, is the new challenge. We have a strategic plan. Every 5 years, we look at education, socialization, all these different roles. And when I have presented a proposal to add healthcare to that strategic plan, I was denied. However, they took what I suggested and dismantled it and put different things into different places. Do you know what I mean? So I don't know if it's a political thing or if it's just a not ready thing or if it's not understanding the higher role of nurses in this country or what exactly it is. I continue to find information and try. If something doesn't work, I try again. I'm not willing to give up because I feel like this is my calling. I was a faith community nurse in a Christian and Catholic church for many years. And I saw how well it could work and serve the population very privately, discreetly, even in small numbers to address what's needed. And also the data is integrated into our so it is really a good fit. And sometimes things take a little while to catch on, or you work, and then one day you walk away and everything works and you're like, oh my God, finally it came together. So what inshallah, but it's been really fun working with them.
So I want to make sure that we are going over a little over our limit. I don't want to hold anybody. Dr. Padilla, do you have I know you have to go. Do you, any final words? Anybody who wants to? We're pretty much at the closing, but I want to thank everybody. And Brother Isa has a question.
I do. Assalamu alaikum.
Wa alaikum assalam.
My question is kind of how do we engage in supporting and promoting mental health and wellness within the Islamic communities? It just seems like, I don't know, from what I've seen, that it's not necessarily, there's not necessarily a lot of support for this. It's like, oh, you make dua, you can make, make salat, go do these types of things, and that will help you, instead of like, a more kind of comprehensive, like the last sister's response about the disorganization. How do we imagine kind of creating a space that promotes mental health and wellness in the Islamic community after post-COVID situations? Or
if Dr. Padilla wants to answer that.
I don't have a great answer for that. I think Nancy suggested you should put in a Muslim faith community nurse in the community. I can say thumbs up to that, but I think it's a collective responsibility, and I don't want to say one size fits all. You heard panelists say here, right, that there are different social demographics and economic factors of different mosques, and there are different solutions for different areas. There's diversity, and so I think we should acknowledge that there might be multiple different solutions to that challenge, but they have to be community driven. And our panel here is about patient-centered outcomes research, meaning you have to really think about what the solutions are, the community-centered, patient-centered solutions that are organically developed from the community setting. So I think that demands perhaps a task force, just like we have a financial planning or fundraising task force within the community. We should have these task force. So I'll say that. But what we do know from our PCOR model is that you need a multi-sectoral group together, right? You need to have the multiple voices there, not just doctors, not just the imams, not just the community health workers, all sit together and come up with a solution that's workable in the context of that community. But awareness is the first step, and our town hall today was about awareness. I hope I've set that up for you, Fatima, to take us home, inshallah.
Yeah, thank you so much. I really appreciate everybody coming together and discussing this, some of the technical issues. Thank you again for all your time and effort, and we will be keeping in touch. And I will see everybody online. We would be sending out the recordings, by the way, as well as the PowerPoint slides presentation. Thanks, everybody.
Thank you. Have a nice evening.
Thanks, everybody, for the
Thank you.
background.
Assalamu alaikum.
Well,
Assalamu alaikum.